Hi, Dr. Choudhury.
Hi, good morning, Darryl.
Hi, thanks for coming to our conference. I'm grateful for your time. Can you tell our audience what you do and where you do it?
Sure. So my name is Atish Choudhury. I'm a medical oncologist at Dana-Farber Cancer Institute. I serve as the co-director of the Prostate Cancer Center at the Dana-Farber and Brigham Women's Cancer Center. And I see patients, and I also do clinical research, mostly around novel therapies in prostate cancer, but also in biomarker studies from tissue and blood specimens from patients participating in those studies. And I'm excited to talk to you today about some of this work.
That's super. And by the way, so is Dana-Farber actually Harvard University, or are they separate institutions?
They're separate institutions, but Dana-Farber is one of the cancer centers that's affiliated with Harvard University.
Okay. A lot of people wonder about that who aren't from the Cambridge, Boston area. So I thought, why not get a hit of that?
Sure.
Okay. So for our audience today, the deal is you have the opportunity in 2021, moving forward, 2022 and onward, to actually try to gather information from tissue samples and blood samples from patients.
Mm-hmm.
Why are you doing that?
Yeah, so, there's a variety of, different kinds of biomarkers. That's a very generic term for just different kind of molecular studies that can be performed on, different sort of specimens that can be derived from patients. So, there are two forms of biomarkers, and both of them have some clinical utility. One is called prognostic biomarkers, which are, things that we can test from blood and tissue that basically tell us, how well are patients in this particular setting going to do. So if it's from patients with localized disease, it might be how likely is it for the treatment to be curative versus the cancer coming back. And then for advanced disease, in general, how long is this person going to live with advanced cancer compared to other people in this particular situation? Then the second type of biomarker is a predictive biomarker, which is, is there something that we can determine that a patient is more likely to respond or benefit from a particular treatment compared to something else?
So I heard two different things with the prognostic side. The idea that you're making selections on treatment possibilities, but you're also trying to understand what's going on inside the person, whether they do treatment or not. Is that fair to say?
Absolutely. So, among the types of biomarkers that are prognostic that we think might be at least most clinically relevant is the decision that many men face, as you know, of whether their primary prostate cancer actually needs treatment at all, or whether they can, undergo just active surveillance. So for patients with low volume and low risk prostate cancer, most likely we can be very comfortable with just active surveillance in patients in that particular situation. But there are some patients where, there's either very high volume of low risk disease or maybe a very small volume of more intermediate risk disease, or they have other medical comorbidities that might make treatment more challenging. And we might want a little bit more information on, is this a more aggressive looking kind of cancer or not, to then help us with that decision on surveillance versus active treatment. And that's something that is under active study. So to this point, it's really not been demonstrated that using these kinds of tests to help make those decisions actually provides sort of meaningful benefits to patients. But because these kinds of studies are pretty well validated as far as being prognostic, they are in the guidelines for us to be able to use if we feel like it's going to help us make a decision.
So, I mean, this sounds almost miraculous in the sense, guys with prostate cancer, they've gone through the initial steps of PSA testing and digital rectal exams and such, all tempered with the idea that neither of those tests really tell you whether or not you've got prostate cancer or what's going on, which sort of sends them to the second tier, second line thing, where it's the MRI, maybe, maybe not, but certainly a biopsy. And even with a biopsy, it's sort of a throw a dart at a large wall and see if you hit the donkey on the nose, or whatever metaphor you want to come up with. But it's a bit of a crapshoot as to whether you're actually going to get enough tissue that truly describes what's going on in the prostate. Are these liquid and these blood and tissue based things really accurately describe, just sort of pushing all that, primitive kind of investigation aside and giving us a true picture of what is going on?
So definitely not putting it aside. So I'll just be a bit more specific about what I'm talking about here. So there are basically three tests that are approved for localized prostate cancer that have been demonstrated to have some prognostic potential. And these are based on gene expression within the prostate cancer cells. So they're called Prolaris and Oncotype DX and Decipher are the names that we give to them. And they basically add to everything that we know from the clinical features. So certainly if you have an MRI before the biopsy and you use that MRI to target any suspicious areas, then we do actually feel pretty comfortable that the clinical staging, the MRI, the Gleason score, and the PSA provide us a lot of information as far as, what's likely to happen over time and, who are patients who are appropriate for surveillance versus not. And it's a very high bar for any molecular test to actually surpass our just clinical information. And the Gleason score is definitely the most important of all of those features that I had mentioned. Now, that being said, there's some situations that even with all that clinical information, us as doctors are a little bit borderline around being able to counsel patients, is this the lowest of low risk cancers, or is there something more suspicious here that if you're nervous, that it would be very reasonable to treat? Or if it's intermediate risk, but it's really not as aggressive as other people's intermediate risk, can we feel comfortable with surveillance? So these are definitely tests that are used in conjunction with the clinical information and clinical judgment, but they do not replace them by any means. And they're definitely not miracles. They just provide just a little bit of extra information that can be helpful to us and the patients.
So for a patient, they're sort of understanding it slightly differently than the way you described.
Mm-hmm.
When you're doing a biopsy and the slices of flesh go to the pathologist,
Mm-hmm.
pathologist is looking at them, through a binocular microscope or on an LED screen or whatever, and having colleagues and residents and join him or her and figuring out what the patterns are.
Mm-hmm.
You describe the patterns as Gleason or with the new Epstein group, but basically it's eyeballs looking at cell structure.
Mm-hmm.
What is the fundamental difference between eyeballs sort of filtering out or describing cell structure versus a chemical version of that, as a genetic investigation that's
Mm-hmm.
also looking at the same tissue and basically coming out with perhaps a different metric, but is still looking at that same sample?
Yeah, so that's obviously a very tricky question to answer. What I would say is that an expert geopathologist is actually very good at understanding the biological behavior of cancers. It's very hard for a molecular test to actually surpass Gleason score as far as a predictive prognostic biomarker for how people are likely to do. So what these molecular tests are doing is taking something that looks the same under the microscope, a Gleason 6 cancer, and then, does this gene expression information to add a little bit more context to it. And why that works, I would say that is not very well understood. It could be that some of this molecular information can give some guidance on how likely there might be to be higher Gleason grade cancer somewhere else in the prostate, because obviously the pathologist is looking at, the tissue that was taken. And certainly the molecular testing is also performed just on the tissue that was taken, but there might be some clues or signals that are present in that tissue that might give an idea of how likely there might be more aggressive cancer somewhere else than what just looking under the microscope would do. But I think that there are pathologists and molecular pathologists who might slightly disagree with that characterization, but that would be my best interpretation of what we're coming up with these more molecular kind of tests.
And when you're doing the blood version of that,
mm-hmm.
the blood is sort of, you're looking at parts of the blood that have been expressed or shedded or squeezed like a sponge, and the drops are floating through your bloodstream, and you're looking for clues in those drops floating in your bloodstream for what's going on around your body regarding prostate cancer. Is that fair to say?
Yeah, so that's another set of tricky questions. You're very, very cogent in the questions. So, there are different types of blood tests. So in the case of, more localized prostate cancer, most of the study that I'm aware of are basically blood tests to give more clues in addition to PSA itself on how likely, a man has prostate cancer just even before a biopsy is done. And some of these are called 4K score or prostate health index. And that really is more in the purview of the urologists. I usually see patients after they're already diagnosed with prostate cancer. And there's not much in the blood that I'm aware of that helps in sort of the management and guidance of localized prostate cancer after it's already been diagnosed. So when I talk about blood-based biomarkers, that's really for patients with more advanced cancers where actual metastatic prostate cancer can shed DNA into the circulation. We call that circulating tumor DNA or circulating cell-free DNA. And there are very, very sophisticated tools and techniques to be able to analyze DNA from a patient's bloodstream, actually identify, what proportion came from cancer rather than just normal cells, and then be able to identify, basically tumor-derived DNA in the bloodstream to then identify some of these predictive biomarkers that we were talking about. Are there particular genetic features that we can find in advanced cancer that might predict responses to different sorts of treatment? Localized prostate cancer actually does not shed much DNA in the circulation, so we don't do circulating tumor DNA testing on localized disease.
Okay. And, another thing that comes up in the support group network is if you can do it on blood, why can't you do it on lymph? I mean, people are always talking about, doing biopsies of adjacent lymph nodes and such.
Yeah.
And, and from that, most patients get like a 5-minute lecture on what lymph is, and most are surprised there's a whole nother lymphatic system going on and such. Why are there tests or investigations that use the lymph material?
Yeah, so if the prostate cancer has spread to lymph nodes, and there's actually kind of a tumor there that's that you can biopsy safely, then that actually is a great source for this genetic material to do this testing. And I would say it's probably a better source for some technical reasons that we might get to later than blood. So absolutely, lymph nodes are a great source of material for this sort of testing. As far as I know, there's not easy ways to actually sample the lymphatic fluid. So the blood is definitely, obviously very easy to sample. It's just a basic blood draw. A biopsy of a lymph node is a more involved procedure. But in most cases, when there's a lymph node that's large enough to biopsy, it is relatively straightforward and safe, and often gives us a lot more information than just a blood test would.
Before we move on to advanced stage testing, which is really what we're here to talk about, I mean, most patients will also wonder, why are you biopsying my prostate? If the cells are in the prostate, what do I care? It's when they metastasize that it's most troublesome. Why not just biopsy all of the lymph nodes near the prostate?
Yeah, so again, if there are lymph nodes that are large enough that are suspicious that there might be prostate cancer there, then certainly doing biopsy of the lymph nodes is reasonable in many cases. But really, most of the time when people present with localized prostate cancer, there's not evidence of cancer anywhere else, including the lymph nodes. And so, as I'd mentioned before, the most important piece to understand how likely a treatment is to be effective and how likely a cancer is to recur is based on the biopsy of the prostate and the Gleason score that we would determine from that point. And it also gives a lot of additional information regarding treatment. So, if somebody's going to go to surgery, certainly it helps with the decision on whether this is something that is, worth even treating, or it could just be surveillance. If people go to surgery, then the Gleason score and the staging that we would determine from the surgical specimen would be then helpful to determine if somebody needs further treatments after that. But if somebody is going down a radiation route, then you need the Gleason score to understand whether you need hormonal treatment at all, whether you need a short course of hormonal treatment, like for just 6 months, or whether you need a longer course for 2 to 3 years. And there's no information beyond if you don't have the Gleason score that helps make that decision.
Yeah. Let's talk about molecular biomarkers for men in the advanced stage. And also I do want to touch on transgender women and the complications that presentation poses for this kind of discussion. But
Sure.
for now, let's just give us like a 90-second or so version of your talk on what molecular biomarkers, what values molecular biomarkers have for men in the advanced setting.
Yeah, so in the advanced setting, there are basically 2 that are relevant for FDA-approved treatments, and everything else is really considered more exploratory or investigative, and we have a lot of clinical trials around. So the 2 main ones are actually genetic features that are found in other cancer types. So for example, women who are predisposed to breast and ovarian cancers often carry inherited alterations in particular genes, and the most prominent ones are called BRCA1 and BRCA2. And again, they predispose women to breast and ovarian cancers. But in men who carry alterations in those same genes, they tend to have an increased predisposition to prostate cancer and BRCA2 in particular. So for patients who have alterations that cause them to lose function in BRCA2 and related genes, it turns out that some of these treatments that were initially approved and developed for breast and ovarian cancers, and they're called Parp inhibitors, can have activity in patients with prostate cancer as well. And so we have 2 that are approved. One is called olaparib, and the other one is called rucaparib. And you do need to find one of these genetic alterations for them to work, because people who don't have those particular alterations don't respond to these drugs, at least on their own.
So these tests are just set up to parse out or figure out, what percentage, whether you fall into the small group of guys that would respond for these 2 treatment opportunities, right?
Exactly. And even within the ones who fall into sort of the approved set of genes when altered, can respond to one of these treatments, it turns out that there's still a lot of uncertainty, even in 2021, around which gene alterations actually confer the highest likelihood of actually responding. So BRCA2, definitely, those patients have a high likelihood of responding, whether it was an alteration that you inherited, what we call a germline alteration, or whether the cancer over the course of its evolution actually lost BRCA2, what we call a somatic alteration. But there are other gene alterations in, again, other genes called ATM, CDK12, that fall into the category where olaparib is approved, But it turns out that in the studies, it's not clear how well patients with those particular alterations respond. So it's an option, but it's not, again, it's not magic. And some patients respond and some patients don't respond very well at all. But absolutely, that's what that genetic testing is for, to basically get a sense of, is this a treatment option? And then if you're treated with this, how likely is it that you're going to respond?
Right. And the genetic testing, do you have to do surgery to do that? What do you do?
No. So again, there are two types of genetic tests that one could do. So one for the germline testing, that is, did you inherit a gene alteration from your parents? That can be detected through a couple of different types of tests. One is through saliva and one is from blood. And it's just sent to a lab to see, what are the different, DNA alterations in cancer genes that you were born with. Then there's a second type, which is to look for the somatic alterations. What are the things that developed in the cancer over the course of time? And in order to do that testing, you would need a biopsy, as we talked about before, of those lymph nodes, and that can be sent for a variety of kinds of genetic tests. And so things that the patients in your network might have heard of would be something like Foundation or Caris, and there are different other ones to do that sort of genetic testing. And then from the blood, as I mentioned earlier in this talk, there are ways to do circulating tumor DNA tests. And those are companies like Guardant and Foundation have done those sorts of tests as well. But there are a lot of different companies that do this sort of testing and report, what are the alterations that are found, and then what kind of treatments might be relevant based on what's been found.
So the companies you mentioned are primarily U.S. based, or looking for U.S. United States customers or patients or such. Are there similar kind of things in other parts of the world, perhaps superior things?
I'm not sure about superior, but I'm sure they exist. And I apologize that I really don't know the names of other companies in other places. But the testing is very similar in terms of what people are looking for. And I'm sure that there are companies and for your international patients that would be able to do that.
Right. And is this if it's just saliva, we're talking something more sophisticated than the commercial, like 23andMe things, or is that adequate?
So 23andMe, and again, again, the actual, intricacies of why that's not quite adequate is a little bit beyond sort of my specific expertise. But, that test is not a approved clinical test specifically for the cancer genes, because certain cancer genes do require a kind of a deep dive to look for alterations. But the tests that we do send patients for, and again, they're through Ambry Genetics, Invitae, Color, those are the common companies that they do it. The test is essentially very similar to 23andMe. It's a saliva or blood test that looks for the DNA that you inherited.
Yeah, the best tests are spitting tests. What can be better than just and you're done,
Yeah,
yeah. So you've discussed tests that sort of figure out whether or not a particular kind of Parp inhibitor style treatment will be effective or not.
Mm-hmm.
And even there, you've mentioned there's a bit of a gray area. Maybe, it would be useful for people who 2 years ago would have been told that don't bother or so.
Mm-hmm.
What else can an advanced stage guy do or learn, or what kind of conversation do you have to say, here are tests, here are samplings we might do, here are
Mm-hmm.
questions I have, and I want to sample a part of your body to get the answer?
Yeah, so in addition to the Parp inhibitor question, a lot of patients come to me and ask about immune therapies in prostate cancer. And so as many of the patients in your network are aware, there are drugs with brand names Keytruda or Opdivo and many others that are approved in lung and kidney and melanoma and bladder cancers that have shown very little activity in prostate cancer in general. But there's another set of gene alterations that are present in maybe 2 or 3% of men with prostate cancer, which are called mismatch repair or microsatellite unstable cases, which is something that we often see in colon cancers and uterine cancers and can be inherited similarly to those BRCA gene alterations that would suggest that patients can respond to these immune therapy drugs. And in particular, pembrolizumab or Keytruda is approved for advanced prostate cancer and really any advanced cancer with alterations in mismatch repair or microsatellite unstable cancers. So beyond that, as I had mentioned before, everything else is exploratory, and there are other gene alterations in other growth and signaling pathways within prostate cancer cells that might suggest that particular kinds of more experimental treatments could be effective. And so because those other drugs are not yet approved for prostate cancer, in order to try out those sorts of treatments, you would certainly participate in a clinical trial. So for example, there are common alterations in pathways called the PI3 kinase signaling pathway or AKT signaling pathway, and there are particular molecules, drugs, that are maybe approved in other indications that we're now testing in prostate cancer. The other types of things that we're testing is, are there ways to make Parp inhibitors or immune therapies work in more patients other than the ones who have these particular gene alterations? So for example, we have trials combining Parp inhibitors with other sorts of treatments to see if they might work in patients even without BRCA gene alterations, or to combine particular drugs with immune therapies to see if they might work even in patients without those mismatch repair deficiencies. And so I think that, if you have advanced cancer and you're not a candidate for a biomarker-directed treatment just by its FDA label, certainly it would be relevant to look into clinical trials that are available that might target your particular specific alteration or might be a bit more generic, but testing novel approaches.
And there are how many of these trials currently, would you think?
I mean, thousands and thousands internationally. And so it really depends on, what the institution that you're at has in terms of their particular portfolio. Again, because most of these types of studies are investigational, you can't promise any patient who's participating that they're going to be of benefit. But certainly I do recommend most patients with advanced cancer who are candidates for trials to look into what might be available at their closest academic center and see if they might qualify for something that might be of help to them. But even if it doesn't necessarily directly provide help to them, certainly participation in a clinical trial helps in our overall understanding of the types of treatments that might be beneficial to other patients down the line.
Yeah, and I wanted you to actually say thousands and thousands, because when people are told look for a clinical trial, they're for most cases they're thinking, oh, there's one or two, I hope I get in. But there are lots of opportunities, and aside from asking your doctor and the institution and the hospital you're at, I mean, Malecare.org has a really snazzy trial finder app at the bottom of the webpage that I want more and more people to use. It's certainly an improvement over clinicaltrials.gov, and will get you someplace. But as much as we're jazzed up about clinical trials, it's real world experience that we're most concerned with. I mean, we're like one of the largest, if not largest, prostate cancer support networks in the world. And, one of the consequences of that is we get to hear patients tell about their experiences with
Mhm.
PARP inhibitors, with X, Y, or Z therapies and treatments and such. And almost never do they match the clinical trial outcomes, and usually,
Yep.
unfortunately, in a negative sort of way, both in terms of quality of life and in terms of outcomes. And we usually hear that from family members, unfortunately, after the person's passed. So what is your, I mean, you see patients, what
Mhm.
are you, I mean, what's your real world experience in terms of using molecular biomarkers to really help people along?
Yeah. So again, it's all about setting expectations, because actually these standard treatments for prostate cancer, in terms of chemotherapies, for example, are very effective and actually pretty well tolerated in most people who get them, with side effects that can be managed. But you use the word chemotherapy, and a lot of people are very resistant to that idea, even if they're symptomatic from their cancer, and that's the treatment that's most likely to actually shrink the cancer, improve quality of life, and prolong survival. And so something like a PARP inhibitor, the number of patients who really have a dramatic response is kind of a minority, as you had mentioned earlier. So, just setting expectations for what you're likely to experience, it's a tool. It can lead to some tumor shrinkage in some people, and that tumor shrinkage can last for some amount of time. But cancers are tricky, and they find their ways around pretty much everything that we use. And so when we talk about side effects to PARP inhibitors, we just say, again, it's highly variable from person to person. A lot of people can tolerate PARP inhibitors at their full dose, quite well, maybe with some mild fatigue, mild nausea, but not really much else. Whereas some people at a full dose of a PARP inhibitor can have quite profound fatigue. Their blood counts can go down quite a bit. You can experience quite a lot of GI symptoms. And we try to manage that with dose reductions or holding doses as needed. We can give blood transfusions. We can give proper medication for the nausea and the diarrhea. And so usually we can find a way to get people through. And again, what is the goal of treating advanced cancer? It's really to maintain a reasonable quality of life as much as we can. And so it's if the treatment is side effects are worse than whatever quality of life benefit you might be getting from it, then it certainly might not be the treatment for you.
Yeah, I mean, knowing when to stop treatment, I think, is one of the high arts of medicine that
Mm-hmm.
is rarely discussed, and certainly not within a patient-doctor consult until you're well beyond that. You're over the edge, over the ledge, and you're not really having a valuable discussion. You're just looking at the end of life and trying to make it comfortable. The
Mm-hmm.
idea of transgender women presenting with prostate cancer is not new to Malecare. I mean, we've been seeing
Mm-hmm.
women patients since 1999. Very few. I mean, think I've personally met less than a dozen in my career, but the idea of more awareness and more opportunity to treat transgender women is certainly coming in this decade. What
Mm-hmm.
what are your thoughts around the utility of biomarkers for that?
Yeah, so there's nothing that we know of that would be different in transgender women compared to men in terms of the susceptibility to PARP inhibitors or immune therapies. The one thing that I can think of that might be different is that for patients who are on estrogen supplementation, actually estrogen does lower the level of testosterone in the body on its own, and actually makes testosterone levels very low. So when patients who are on estrogen present, it's very important to check a testosterone level. And those patients actually might be sort of castrate to start with. And then we actually might need to start our treatment paradigm, in that sort of castration resistant setting that we talked about. But otherwise, I can't think of any other relevant biological differences that would change anything that we discussed to this point.
Right. And specific to actually germline genetic stuff, I mean, there are Mennonite communities, Hasidic religious community. I mean,
Mhm.
they're really an under a less a more stuff to be investigated set of communities of people that have just married each other for generations and generations and generations.
Mhm.
And to what extent do we understand the value of molecular biomarkers for those kind of people, for people
Yeah,
who have
so
just this inherited genetic thing, sort of like
yeah,
going on
yeah.
a
So certainly, as you're probably aware, patients of Ashkenazi Jewish heritage, for example, have a higher likelihood of germline alterations in one of these BRCA genes. And so certainly, you know, even outside of a prostate cancer setting, it might make sense to do germline genetic testing to see if you're in a risk category that you might need to do additional screening even before any cancer diagnosis. And certainly finding of BRCA1 and BRCA2 alterations in women would suggest, particular increased screening for breast cancer. And how that applies to prostate cancer is not fully clear. I think we just say that PSA testing might start a bit sooner if you are known to have one of those alterations. But once you're diagnosed, certainly you should be tested. And again, the treatments based on those molecular biomarkers are approved in the advanced setting, as we talked about earlier. But there are definitely trials to look for, whether PARP inhibitors, for example, could be helpful even in localized disease or early in the development of advanced disease rather than late in advanced disease. So all of these studies are currently enrolling, and yes, and in those populations, we would definitely have our antenna up even more to look for inherited predispositions.
Yeah, as we're starting to wind our conversation down, and thank you for this. It's very clear, and I think will help people come up with really cool questions for their doctors and such. I mean, are there tests to tell me how long I've got to live?
There are, and so the tests about prognosis are generally kind of multivariable, meaning there are models where we can input sort of what your treatments were before, where your cancer is, what are some levels of particular chemicals in your bloodstream that define is the cancer having impact on your bone marrow? Is it having impact of your bone? And you can put it together to kind of come up with an overall perspective of where I am on this spectrum. Do I have very aggressive kind of cancer where my prognosis is maybe limited, or does everything seem like, I have years to go with this? But I would say that that kind of tool is very tricky because a lot of the data that was fed into those sorts of models is old data and doesn't include a lot of the newer testing and treatments that are available. So I think what's important is just to make sure that you have very open lines of communication with your physician and just along different steps of the way, and understand that a lot of what it relates to prognosis is how well you respond to treatment. And some people want to know in a very granular way, what to expect, and some people want to know less about that. So I think it's very important to have that conversation with your doctor as well, to just again set expectations, know where you are on a spectrum, but also just understand that there's a lot of uncertainty. And when doctors are very cagey about providing prognosis, it's not because we know something that you don't and we don't want to share. It's because so many things are unpredictable, and it's hard to really give a great estimate.
You just hit on a very important thing. You can look, I mean, patients, you can get a copy of these reports.
Mm-hmm.
Yeah, and you could Google the terms and maybe you'll understand or not, but you'll get a sense as to whether your doctor's holding back something or not. Even if you have the most angelic and doctor with an extraordinarily terrific relationship, every patient on earth is going to have a moment of doubt as to whether they're being told everything.
Mhm.
And the remedy for that is just to use Google, frankly, and just copy and paste the terms from your reports in there and see what you could churn up, and then ask follow-up questions. What do
Yeah,
you
I
think
mean,
of that?
there's a yeah, I mean, so Google is a very useful tool in a lot of different ways, and what's very tricky is to find accurate sources of information, information that's relevant for you in your particular situation. Because if you Google prostate cancer, that's a whole spectrum, from very indolent, very localized disease to very advanced and very aggressive kind of disease. And what you find there that's relevant to you and your particular situation is often very challenging. So I think what does make sense to do is, if you're interested in reading, try to find sources that come mostly from academic institutions or your foundation or Prostate Cancer Foundation, or things of high quality, and write down some questions to bring to your doctor and just see what might be relevant for you.
Yeah,
And
actually, but let me, because I didn't mean like a general kind of Google thing. I
sure,
mean,
of
like,
course.
you get a report, if it's online, you could just cut, if you have like carpi sarcoma, I don't know, whatever kind of
Sure, yeah.
phrasing, something extraordinarily intricate in the pathology report or the molecular biologist report or whatever, terms that I've never heard of, you
Hmm.
live with, but no other human being on earth should really be aware of any of this stuff.
Right.
Just to get the gist of what's going, just so you feel confident that you're not being, soft pedaled on what your condition is. Obviously, prostate cancer is too generic a term to Google and get any value out of.
Hmm.
But yeah, and also look for your papers. I mean, it's
Yeah, sure.
um, scholar.google.com is a really great source, as well as PubMed and ResearchGate and a few others. As we close this out, what are you doing? What are you looking at for 2022 and forward? And what do you feel like confident, or what you're going to put your $10 on as, something useful in the future?
I mean, I think the thing that I'm most excited about is, can we cure men in 2021, men and transgender women in 2021, with the novel imaging and the novel molecules and novel strategies that we used to tell patients back 10 or 20 years ago that you were inevitably going to die of prostate cancer. And what does cure mean? Cure means to treat the cancer in an aggressive way, wherever it is, but then stop treatment, recover your testosterone, have a good quality of life, and never need to be treated for prostate cancer moving forward. So can we continue to push the envelope on our ability to do that with the new things coming down the line? And I think the more and more patients that we can actually get off treatment is actually going to, provide benefit. Certainly for patients who are on treatment and need to stay on treatment, then the goal is to have more and better tolerated treatments, better supportive care, so that people can have as great quality of life as possible for as long as possible, even living with prostate cancer.
Yeah, and are you involved in a particular trial or investigation at this moment, or planning for
Yes.
20? Go ahead.
And so I don't know exactly how much I can make public, but I am working with the National Lank Cancer Institute on a study to actually stop treatment for patients with metastatic prostate cancer after a couple of years, and see how long they can go before they need to resume treatment, and see, if we can quantify the benefits to quality of life and other health outcomes for actually stopping treatment. So that's one of the main studies that I'm working on, in addition to some of these combination treatments that I had mentioned to you before about PARP inhibitors combined with other molecularly targeted drugs and immune therapies with other molecularly targeted drugs to expand the number of patients who might benefit from those sorts of treatments.
Yeah, and thank you for looking into that. Mailcare's question of the year for 2022 will be some version of when can I stop treatment?
Hmm.
With a positive sense.
Yeah,
Not just like time to stop treatment because nothing else is helping, but when can I stop treatment because that's a good thing to do now.
sure.
Yeah.
Absolutely.
Dr. Choudhury, thank you very much for this wonderful discussion, and I'm sure our audience is going to get a lot of value out of it, a lot of help, and feel more confident asking their doctors questions that they may not have thought of an hour ago. I'm grateful for your participation in our conference, and welcome to Mailcare's faculty.
Oh, great. Thank you so much for this invitation. It was really a delight talking to you.
Okay, bye.
Take care. Bye-bye.